Um, as I say, the topic of the talk was SARS-CoV-2 or COVID-19 infection in pediatrics or in children. And I think the only real way I can start with this is to say it's a journey, and this is kind of my journey so far, because as we know, it's a pretty new, well, the disease is new, but certainly what it's doing in children is even newer. And so I'm just going to share sort of what we've been through, and I think the most important thing is certainly no disclosures other than I am involved in Netcare 911 as an aeromedical consultant, but certainly I won't have any influence on this talk. And I think the most important thing is that I'm certainly no expert. I think it's been widely accepted that there are very few experts in this particular field with regards to COVID infection in children. But I think, yeah, that's the most important thing, is that this is a learning journey for everyone as we go along. And I think we are quite far in terms of being able to pin down the very classic presentations of some of the children that are presenting with these common things that I'm sure everyone's heard in the media with regards to the multi-inflammatory syndromes, or the hyperinflammatory multi-organ syndrome that's going around. But we certainly don't have that as a majority of our presentation in Johannesburg. Western Cape is a little bit ahead of us because their surge was a bit earlier, and so they are seeing a lot more classic presentations, but it's not the easiest thing. So basically, what are we going to cover tonight? I thought we'll start with local experience in terms of what we've sort of been involved in the last 2 months at Chris Hani Baragwanath Hospital, and certainly some of the controversies around this whole COVID story. And I'm sure many of you know a lot about what's happening in the adult world. In the pediatric world, it was quite difficult because from the pediatric side of things, do you prepare the same way as what the adults were? Yet we know that there were very few children in the beginning that were exposed, that first came out of the China literature, then out of the European literature, then followed obviously the US literature. So that's quite an interesting topic in itself, and I want to touch on that. And then we're going to really get into the meat of the talk, which is this whole thing around the pediatric inflammatory multi-organ syndrome, or the various different names that it's called, MISC as well. We're going to have a look at, maybe because I'm a bit biased, there's a big tendency for this syndrome or this COVID-related hyperinflammation to infect the heart. And then I just want to touch on cardiac arrest. And if many of you know me, my other hat is with the Resuscitation Council, and we had to write some cardiac arrest guidelines, which I think for this talk, specifically speaking to children, becomes quite difficult because COVID is not presenting the same way as what it presents in adults. And so therefore, can we have the same CPR guidelines? And maybe I'm preempting something that needs to be reviewed from us in the Resuscitation Council. So if we start, I was very privileged to be asked by a colleague of mine at Barra, Kuben Naidu, who said to me, Dave, you've done a whole bunch of work trying to put together what we require for a COVID ICU. So we were also approached by colleagues of ours that run this journal in Brussels. And they said, tell us, how do you prepare COVID-19 ICU in South Africa? And at that point, when this was published in, I think it was April, or we wrote it in April, it was the calm before the storm, because now we had to try and put this whole thing together and say, well, what resources do we have available, and what are we going to try and procure to set up an ICU that will cater for, and at that stage it was adults and pediatrics. And when you look at what we were trying to create and what we were tasked to create, we were increasing our adult capacity by about 70% and our pediatric capacity by about 50%. And as I say, you're more than welcome to read this issue, and there's nothing massively scientific there. It's just a really interesting article as to, I'm sure many of those that are that are listening to this webinar went through similar challenges in terms of what resources do you put across, because we're already stretched. We know that ICU resources, particularly from the nursing staff perspective, is really, really stretched, and especially if we want to offer quality care. in the form of the standards that we often set: 1-to-1 nursing, 1-to-2 nursing if it's a high care patient. How do you do that when you can't always provide that service at the best of times? Now you need to increase your capacity by over 50%. Where are you going to get that kind of standard to maintain that level of care? And so those are some of the controversies and the challenges that we had right in the beginning. Right now, we're actually sitting with a challenge that we're sorting out with regards to our pediatric burns unit. And I use this as an example. So if we look at the pre-COVID era, we were a lovely tight unit of 7 ICU beds. We had 6 beds for children in one cubicle or one ward, another 6 beds for children that required a little bit more higher care, so not sort of high dependency area, but patients that needed to be looked at a little more often and could be on continuous monitoring, etc. And then we had a 3rd cubicle where all our big children that certainly needed far less sort of nappy changes, so anything from 3 years above would be seated. And we then had to, we had our first COVID burns patient, and now all of a sudden we've got to cater for these patients. So how do you do that? And as you can see on the right hand side of the screen, our ICU beds did drop slightly. In fact, I'm maybe overestimating it. At times, depending on staff, we may only have 4 non-COVID ICU beds. Then our first cubicle became the entire COVID area. They had to house the ICU patients as well as the non-ICU patients. Our second ward, which was previously housing at least 6 sort of infant burn non-COVID patients, now is our PUI ward for everything. So all of a sudden that doesn't hold any long-term patients. And our third ward that had all our big children needed to be an area where the COVID staff, doctors, nurses, etc., looking after these PUI and COVID patients needed to have an area where they could rest, they could have tea, they could go to the bathroom, etc. And so you can see our capacity all of a sudden changed, so much so that we then had to employ the pediatric surgical ward to house a lot of the burn children, which on our premise is about 200 meters apart. So where's the solution? And we've come up with that solution, and it's a work in progress where we're actually bringing everything back to the unit by the use of converted containers, and we're allowing at least then all our staff to be in one area. But it's taking a lot of preparation, additional funding, and it really is quite a massive sort of structural change as well as positional change within the functioning of the unit. And that's just to cater for COVID burns patients. So there's some serious challenges that are going around. And what are some of the controversies around that? Well, the controversies are, if we look at the statistics, how many COVID patients are you getting? And what are you doing to change your entire structure to cater for those patients? In other words, what's happening to all the patients that are non-COVID? Are they any worse off? And I didn't put it into this talk, but there's a lovely paper that was published by one of our vets. In fact, I think it is one of our Baragwanath doctors that looked at what's happening in the community health centers. And there's a major effect there, far worse than what we're seeing in the hospitals, that I don't think everyone is taking note of. However, if we go through what's happening at Baragwanath Hospital, so these are really approximated, and these are just tallies that we're keeping. They're not validated and ready for publication or anything like that. But I think this gives a really good idea of, and perhaps look at that speech bubble before and look at what Baragwanath generally had. So in any particular day, our outpatient department, so this is not the specialist clinics, this is just the walk-in department that can see children with chronic illnesses that perhaps don't meet the criteria for specialist clinics, but any sort of walk-in patient that needs to be seen can be up to 250 children a day. So that's quite a lot that comes through our what we call Ward 31 or pediatric outpatients. And then with regards to those patients that get screened, we can have anything from up to 500 pediatric admissions per month. And that's talking pediatric medical. I'm not talking about the surgical disciplines now. So that's quite a significant burden of non-COVID patients that we would see, and and these stats would be comparable to sort of July, August last year. If we take what we've seen this year in terms of July 2020, we've actually had over this month, I'm short of by 3 or 4 days, So it was from the 1st of the month to about the 28th, I think, of the month. We had about 242 pediatric medical admissions. As I say, I'm not counting all the surgical admissions here either. Of which, and you can see that's about half of what we would have in the same time last year. So perhaps one can then also say that COVID has done something, and by our lockdown and all the other strategies that we're doing, children are staying at home. So perhaps they're not getting as sick. I think we need to go and look at our mortuaries perhaps to validate this and make sure that there aren't children dying at home that aren't even getting to hospital. But I don't suspect so. And I think this is actually the case of showing that if you don't let everybody mingle together, you actually keep the infectivity of the viral illnesses that plague us in winter actually a lot lower. But of those 242, we had 25 COVID admissions, which works out to be 10% of all of those admissions. So again, it kind of makes you then look back and say, are we doing the right thing by dumping massive amounts of resources allocated towards COVID, when actually these patients are only 10% of our admissions? If we look at the critically ill, which obviously are then those that require massive amounts of treatments and expensive treatments and takes a lot more of the allocated budget, those are only about 2.9% of all the admissions, of which there were about 7 patients. We had, because Paediatrics at Baragwanath Hospital has combined in terms of their COVID ward, in order to maintain non-COVID space, the pediatric surgical patients also joined the medical patients in a particular ward, and we only had 3 of those during July. So I must commend the pediatric department on what they've done in terms of initially restructuring, and it's not really the purpose of this talk, but they restructured to really focus on this massive load of pediatric influx COVID positive patients. And when they found they didn't have it towards the sort of end of June, they restructured once again the entire system to actually cater for what is required, and then look at all the non-COVID patients for which they're getting their normal high standard of care, which is really fantastic in terms of where we've got to. So from a general pediatric practice, Baragwanath has really got their system right in terms of catering for these patients. But this is obviously in July, when the system had changed. When we looked at the June, and this was a table that came from the Open Gauteng M&M, we had a whole bunch of deaths that were presented by a colleague, or 3 colleagues of ours at Baragwanath Hospital. And I just wanted to show you this to give an idea of how difficult it is to label COVID-19 or the SARS-CoV-2 virus as the causative organism of the 12 mortalities that we had in June, where these patients were COVID-19. And you can see from this table that what one did was, and you can see there are 12 direct causes of death. Many of them had specific bacterial infections. And where did COVID-19 fit in all of this? And you can see that when you put it into the WHO classification, you've got to try and sort of label how much COVID was a causative factor, and it was really difficult, and there were multiple specialists that really debated every single one of these cases. And you can see that not all of them, or very few of them, actually have this definite COVID-19 cause as their underlying or their main causative factor. And so that makes things quite difficult when you're trying to then plan and trying to assign and trying to treat specifically COVID-19 infections. So that was Baragwanath Hospital. What about if we just take, and this is, we're very fortunate to have a whole bunch of guys interested in pediatric intensive care, from pulmonologists as well as pediatric intensivists. And we've got an interest group, and we meet every 2 weeks or so. And this was just a snapshot roughly of the patients that were around the country. And if you have a look at them, these are intensive care units, and by no means is comprehensive. These are just those that are part of this interest group that are interested. And I just did it via the various provinces. And you can see we've actually got quite a small number of patients. 6 patients in Gauteng, obviously being one of the biggest provinces. In Limpopo, only 4 patients in the public sector. KwaZulu-Natal, 5 patients. But what is incredibly interesting is have a look at how many staff between the Pietermaritzburg complex and the Durban complex, how many staff were infected with COVID and were off at some point. Over 600. That's quite an astounding number. In the Free State, there were 3. Eastern Cape had 3, and the Western Cape. And it's interesting when you look at these numbers, because there were 24 patients. And when we looked at it, over 10 of those in the one institution that had 19 admissions, 10 of those 19s were these PIMS patients. And why then are we not seeing in the rest of the country? Why only in the Western Cape? And perhaps that's got to do with the trend that we've seen overseas, that when children that are exposed to COVID, generally 3 to 6 weeks later, do they present with this dysregulated hyperinflammatory or immune state. And we know that the Western Cape peaked way before all the rest of the provinces. So are they seeing what we are still to see? That's obviously still to be discovered, but it's quite interesting when one just looks at those numbers. So we do have small numbers of patients, and I'm again, is this the calm before the storm? Are there going to be a massive pediatric influx, or is this how it's going to be? And we can actually then settle in and obviously classify these patients into the boxes that they need to be. So let's get into the meat of the talk. Essentially, if we look at how this COVID story is presenting in children, it's been called a whole bunch of things, and the most common, or certainly in the European or the American side, American side was multi-system inflammatory syndrome in children, the MIS-C classification. Then the more later, and it looks like this is the more widespread definition, if you had to do sort of a search for this condition, would be this pediatric inflammatory multi-system syndrome temporarily associated with SARS-CoV-2, so the PIMS-TS. But there have been 3 other very early descriptions called pediatric multiple inflammatory syndrome, and then this PHS or PHS in terms of shock or syndrome. However, as I say, PIMS-TS is probably the most common nomenclature used at the moment. So there have been a whole bunch of papers that have been published. And you can see there are a couple of bigger studies, and those were the 2 NEJM studies on the bottom right, the Dufort study and the Feldstein report. But there have been quite a bit that's been published around, and you can see that there's this Kawasaki thing that keeps coming out. I'm sure many of you have heard about that already. But I want to focus pretty much on one of the bigger studies and that were presented, and this is this Feldstein article that came out of the US. And essentially, the summary here was that it was done early on. So this is from March to May. So this was before South Africa really had this sort of major influx of COVID. And for these children to be included into this sort of case definition, there were 6 criteria that they looked at. And they looked at serious illness. So the children obviously had to be admitted into hospital. There had to be a laboratory evidence of infection. Their cohort of patients were under 21 years old. There must have been a multi-system organ involvement greater than 2 organ systems. And they must have had fever for greater than 24 hours with evidence of SARS-CoV-2 infection. Now that's interesting, because the evidence there is either the PCR, which shows the acute infection positivity, or serology, which would be the evidence of previous infection, which is where most of the world is saying that 3 to 6 weeks later. Or if those 2 are both negative, a very strong contact history within the past 4 weeks. So in other words, allowing for the immune system to be primed. And the results of this study was, it was broad, 26 US states, over 186 patients. Very interesting, because remember that this has got a very big Kawasaki disease association, or we think it has a very similar Kawasaki disease-like association. Whereas Kawasaki's is often in the younger children, under 5, around about 4 years old. These children, all the median age was 8.3 years. 73% of those children were previously healthy. Very interesting. So not like you're seeing in adults, where all the comorbid illnesses is what's giving you very high predicted mortalities. These were previously healthy children. 70% of them had either positivity on presentation or the serology positive. And you can see their organ systems, 92% of the children had GIT involvement. And that's very important, because you'll see where the confusion is coming in terms of trying to diagnose these patients. when having this adult outlook where we suspect it's a respiratory virus, we know the coronaviruses, we've all had many of the coronaviruses in our upper respiratory tract, but there's very little, or at least, sorry, the least common presentation you can see, and particularly in these 186 children, was respiratory. It was more GIT, cardiovascular, hematological, and mucocutaneous. They weren't in hospital for very long. Well, I guess it depends on your resources, whether 7 days is long or short, but their mean duration of hospitalization was 7 days. The Kawasaki-like features, 40% of them had those. Now, again, that's quite an interesting one. Is that a lot or is that a little? That's hard to interpret. And what is important is that, and many of us often are not using biomarkers, and I know particularly in the government sector, we don't use a lot of the inflammatory biomarkers, which here in this particular condition you have to do, because at least 4 of them were elevated, and that pinned the diagnosis in many cases. And then lastly, second lastly, the coronary arteries were involved. And this is a specific cutoff. Greater than 2.5 standard deviations is a very specific, it's a very big aneurysm that you see on an echocardiogram. But there's still a lot, so that's what they reported here, but there still can be a lot of coronary artery involvement where you don't reach as high as 2.5 standard deviations. And also those are aneurysms. You may just get lack of tapering in the coronary arteries, which is a sign of this PIMS-TS involvement in the coronary arteries. The last point there was that only 2 patients died. So out of 186 patients, only 2 patients died, which is really encouraging because it means that if we treat them, they can do well. And the other important thing that I'm going to show you towards the end of this review is that we have those therapies. I'm sure many of you have heard, and particularly in the adult literature, there's loads of therapies going on. We had all those beginning, in fact, I'll get to it in a second, sorry. Okay, so if we, by way of an introduction, if we take the adult disease, we know it's predominantly a respiratory disease. Yes, there are a lot of other associations coming through. And in fact, there was a 43-year-old that had PIMS-TS by diagnostic criteria the other day. So there is other overlap, but certainly the majority we know is a respiratory disease where around your second week of that disease process, you have this acute deterioration, this hyperinflammatory acute deterioration. And that suggests that, and this is where this sort of table has come through, and I hope that most of you have seen it, and I think it really does sum up the adult disease quite well. And the point is that when you have a look at what treatment options are available, and we know the studies have gone through, there's a debate on the whole hydroxychloroquine, chloroquine side of things, convalescent, the convalescent plasma, and then certainly these more fancier therapies where you've got these monoclonal antibodies, interleukin-6 inhibitors, interleukin-2 and interleukin-1, and anakinra, the tocilizumab, all of these things that are expensive therapies that not all of us have access to, particularly in the government sector. While in pediatrics, the wonderful thing is that you don't need these therapies because that's not the way the disease process, or certainly the PIMS-TS, is presenting and is needing to be treated. So let's start in the beginning. And in the beginning, in March 2020, it all started in the UK. And I must say, one of the questions that interests me is how come the Chinese haven't reported all of this? Like, why didn't it start there? And that's something interesting that I guess we'll hopefully get answers to in a year or whatever's time. But in March 2020, that all happened in the UK. And it was children that presented to pediatricians. They were severely ill. They were admitted to the pediatric ward and then often into the ICU. And they had varied presentations. They had prolonged fevers, sore throats, headaches, abdominal pain, vomiting, rashes, conjunctivitis. So you can see where this Kawasaki's disease criteria starts to come into things. However, a whole bunch of them developed shock and organ dysfunction, which isn't often the way that Kawasaki's disease presents classically. And you can see there in common, sorry, I've got an 8-week puppy that's destroying the house at the moment. So you can see in common there that there were very specific inflammatory markers: high CRP, high neutrophil counts, low lymphocyte count, which is a very interesting thing, and that's something that all of us can look at on our FBCs when we do bloods on these patients. You don't have to do specialized tests. And then the D-dimers were up. And then, as you can see, the Kawasaki disease features are clinical features, and many of them had these typical features. However, and that was the confusing thing, is that, and remember in March, most of the overseas folk were doing PCRs, not necessarily serology. So they had 37 cases, and if I remember correctly, I think 19 of them had evidence of SARS-CoV-2, and the rest didn't, which then said, can you pin this on COVID, yes or no? And that was one of the conundrums that they were dealing with. So obviously they had to develop a case definition. And what they looked at was, obviously this was a panel of a whole bunch of infectious disease clinicians as well as rheumatologists, and they looked at the case reports that were coming out. And essentially on the 27th of April, the Royal College of Paediatrics and Child Health put a case definition together, coining this whole PIMS-TS story. And really what they said was that it's a child that presents with persistent fever, inflammation, evidence of single, now that's interesting because what we're going to look at is how the rest of the world has also put now criteria to label these kids as PIMS-TS. So they're saying single or multi-organ dysfunction. They're the only ones that actually say single organ dysfunction. And then look at the various organ systems, cardiac, respiratory, renal, GIT, and neurological, and have additional features, which I'll show you shortly. And those also can then fulfill partially or atypically the Kawasaki disease criteria. You should be excluding, and if you look at that mortality chart, if you remember that mortality chart I showed you of the June patients at Baragwanath Hospital, you needed to exclude microbial causes, bacterial sepsis, staphylococcal, streptococcal, other infections, the various myocarditis causing infections, etc. So you needed to exclude those, which can also be challenging, particularly in South Africa, where those tests can take days to come back. And then obviously this SARS-CoV-2 PCR testing that may be positive or negative. There was PCR testing. They weren't talking about serology testing. So obviously, as I said, there were all these case reports that were coming through as well around Europe, and it started to come through in the US. And so essentially the core feature that came through with all of these reports were hyperinflammation, and then three features. One was fever and mucocutaneous manifestations, very similar to Kawasaki's. Features in keeping with staph and strep, toxic shock syndrome. And there were features, or an overlap feature, with macrophage activation syndrome, which is also something we don't often see and probably don't hold in the front of our minds. So quite an interesting disease that had an overlap with all of these conditions. So if we look at now this American study of the 186 patients, what did they look at? The child had to have a fever of greater than 38 degrees, definite evidence of inflammation, okay? And that inflammation was CRP, ESR, fibrinogen that goes down, procalcitonin that goes up, your D-dimers up, ferritin, LDH, interleukin-6, if you can measure the actual interleukin-6 level. So there are a whole bunch of things that you can actually monitor. And that's why in this study in the States, they could do all of these tests. Obviously, we can't, in some of our institutions, do all of this testing, but at least 4 of them were elevated in this particular study. And obviously, one of the following, meaning the PCR, the SARS-CoV-2 PCR was positive, or the antibody test was positive, or you had this significant history. If you look at what the WHO came out, and this is just a screenshot taken from reporting. So if you want to be part of the studies that are looking at this, and remember this is the other definition, MISC, so multi-inflammatory syndrome in children, I just wanted to show you that their case definition, slightly different age compared to what the Americans were including. So this is 0 to 19, not 0 to 21. And this fever has to be greater than 3 days, not just 24 hours. Obviously, these other features, okay, as well as inflammatory features, and then no excluding the microbiological cause. So you can see a slight difference in what the case definition and inclusion criteria would be from the WHO. If we then have a look at a table, and this was kindly given to me by a colleague of mine, Asma Salu, and you can see here that you've got the European guys, you've got the Americans, you've got the WHO, and then Canada has also given their own definition. And you can see that there are differences. The length of fever, not specified in the UK. Greater than 24 hours, greater than 3 days, greater than 3 days. The ages slightly differ. Obviously, they all agree on the inflammation. The organ systems slightly differ. And then obviously all of them say, well, if you've got another cause, then obviously treat the other cause and find the other cause. You can't pin PIMS TS then on as a diagnosis if you have another cause. And I think they all agree that you don't have to have this PCR positive, but the antibody or the exposure is important. So something that does point obviously towards the COVID-2 exposure / infection. If we have a look at the American criteria again, what is their definition on Kawasaki's disease? Well, you've got the very classic, okay, very simple, and it doesn't give you a lot of information as to, because remember, it's not any rash, and so this is why in South Africa we've actually highlighted it in slightly more detail. But Kawasaki's essentially, you need fever for greater than 5 days. And they do make an asterisk to say, if you are an expert and you sort of have seen this and know, able to recognize Kawasaki's fairly regularly, perhaps 3 days is okay. And you need 4 of the 5. So the bilateral conjunctival injection, remember, it's non-purulent, so it's just a conjunctivitis that hasn't got a pussy exudate, because that would be caused by something else. Oral mucosal changes, peripheral extremity changes, so that's edema, and then later on you get sloughing of the hands or desquamation. The rash, very specific type of rash, and just cervical lymphadenopathy. It's actually unilateral cervical lymphadenopathy. So this is quite a broad definition that's a bit modified from the classic Kawasaki's criteria. Whoops, sorry. And if you have a look at incomplete Kawasaki's over here, you can see the difference is there's still the same criteria. However, you don't need as many. Okay, and then there are a few other exclusions in terms of the children. But you also need evidence of inflammation and then some laboratory evidence of this inflammatory or / immune problem. And then they talk about also a positive echocardiogram. And so what are they talking about? Well, either you look at the coronary arteries, and we've said that's your left anterior descending, or your right coronary artery greater than 2.5 Z scores, or decreased LV function, regurgitation, so atrioventricular valve regurgitation. Here is only mitral regurgitation, or pericarditis or a pericardial effusion. So not just the clinical criteria that can clinch Kawasaki's disease. There's a whole lot more if you're going to label it incomplete Kawasaki. So those are 2 of the ways that this MIC or PIMS TS may present. When you talk about organ involvement, and I apologize for such a busy slide, but it just shows you that what sort of cardiovascular involvement, there are many criteria. What sort of respiratory involvement, many different things. You can see if I just pick out one, a lower respiratory tract infection. Okay, so you don't need, it's not very specific in, and very specific sort of investigations. These are general clinical things. So if you've got a lower respiratory tract infection, there's your respiratory organ involvement. You need a second or a third to then make the diagnosis with the other criteria for incomplete Kawasaki's, and you've got your PIMS TS kind of diagnosis. So I want to just refer you, and I haven't put in, because as I say, this talk will then go on for at least 2 hours, but we have in South Africa, the Western Cape PEDS Working Group, of which I'm sure many of you recognize many of these names. This is between Tygerberg and Red Cross, have put together a wonderful version, as well as our Critical Care Society of South Africa under the Paediatric section have also put through an excellent protocol on how to go about diagnosing these kids and how to treat these kids. But what I took from here was just more what we are saying, these are the criteria. So you can just see very similar, the same as what is internationally accepted as Kawasaki disease, typical presentation. But obviously here we are unilateral, non-purulent, painless. We've just given in a lot more detail what those actual criteria are for Kawasaki's disease. The incomplete Kawasaki's is, and why I put this as the Canadian criteria, is because, again, it gives you exactly what the echocardiographic findings are. It gives you exactly what the various blood results are that would then clinch an incomplete Kawasaki's criteria, whereas just our South African just says also look at the echo. So what are they referring to? They're referring to obviously these international criteria as well. What about toxic shock syndrome? And that's a bit of an interesting one. And again, there are various criteria. There are 5 categories. You must have a fever. It's a specific rash, diffuse macular erythroderma, desquamation, but you obviously most of the time will not see that in the acute event. Usually that's following the disease. And obviously these patients will present with hypotension, defined as less than 90 degrees, 90 millimeters of mercury, or 70 plus twice the age for children 1 to 12 years old. Or an orthostatic drop in diastolic blood pressure greater than 15 millimeters of mercury, or orthostatic syncope and dizziness. And then evidence of multi-system involvement. You can see now where this overlap is coming from, where you've got 3 or more of the following systems. What systems? You've got GIT, but look how non-specific it is. Vomiting and diarrhea is all you need. Muscular, severe myalgia or CK elevation, mucous membranes, very similar to, you can see the Kawasaki overlap. Renal involvement, where you look at the creatinine greater than twice the upper limit of normal. Hepatic, you look at your enzymes. Hematological, platelets less than 100. And then central nervous system, where you don't have focal neurology pinpointing a specific cause. You've got disorientation or alteration in consciousness. Specifically, again, from the Canadian Society, and why I put this in is because of this extensive tissue necrosis. They've included that as well. They've included ARDS, which we know there are various criteria for. So again, it depends on where you look. This is the South African, so this would be on our South African guidelines. The Western Cape Working Group put these criteria through. But just to know that there are obviously some. So hypotension with 2 of the following is what is required for toxic shock syndrome, according to the Canadian Paediatric Society. So again, you can see some are broad, some is, there's a lot of overlap, which makes this whole condition a little bit tricky. Macrophage activation syndrome, the big thing here, so what's your big trigger would be the fever. Again, fever for over 5 to 7 days. Your ferritin level very, very high, and that's the crossover that we have with the PIMS TS. And then you need to have 2 of the following as well. Not often we check for triglycerides, but your AST platelets and fibrinogen, very specific criteria for this macrophage activation syndrome. However, there are obviously further tests that you would do for MAS, and I'm just going to leave that there. So again, why is it so important? Why have I spent so much time going through these diagnostic criteria, etc.? Because it influences your treatment and your therapy implications. And again, I'm going to refer you guys to, and I know that this is recorded, so you can easily get this, these references. I'm going to refer you to our document, or just go onto the Paediatric Critical Care, the Critical Care Society of South Africa, go into the pediatric section, and you'll have a great document there. But essentially, before I touch on the treatment, we had a really puzzling experience over the past kind of month, 6 weeks or so, because our first patient, or one of our patients, was a 9-year-old who presented with encephalitis. And this child, unfortunately, again, came back COVID positive, but there's no data on a predominant neurological presentation, seizures, what looked like an autoimmune encephalitis. And luckily, one of my colleagues, Kubir Naidu, was consulted, and he felt that there were subtle signs that, again, didn't put this child classically into the PIMS TS box, but he felt that we needed to offer the child that treatment. And luckily, it also coincided with autoimmune encephalitis treatment in terms of the polygam and steroid therapy that this child got. And 5 days later, retrospectively, we looked at all the data and looked at our 5-day later results, where we did the specific tests, or should I say 3 to 5 days later, specific tests for the ferritin and the D-dimers and all the other tests that we do, which I'll show you shortly. And she actually met the case definition and criteria. And we went into history. She had GIT symptoms. She also had the conjunctivitis. So again, it was really difficult. And that child, we were lucky in some ways to have got the treatment effected so early. But it was difficult because that was one of our first primed patients for this PIMS TS story. We then had another child that my colleagues looked after, an 18% hot water burns, that also was COVID positive, and later on in her treatment started ticking all the boxes for the PIMS TS criteria. And again, it made sense because she had been primed, and now she was getting that dysregulated immune response or hyperinflammatory response, and she was then treated for PIMS TS. We were, and this was an interesting one. Again, also a colleague of ours consulted on a 12-year-old. I think it was a 12-year-old. Sorry, that age might be incorrect, but I think it was a 10 or 12-year-old appendicitis who they did an exploratory lap on, found to be COVID positive, and the appendix was pristine. There was nothing wrong with the appendix. And again, on further investigation, and we treated as a PIMS TS, and the child did incredibly well, didn't even need to come to Barrow as a referral, and the referral hospital was able to manage the child, and I suspect the child's gone home already. We then had another child that presented in a DKA. And this was an incredibly puzzling child, became, flagged COVID positive on PCR and just did not behave. And I'm sure many of us have treated hundreds of DKAs. They do incredibly well. This child ended up in shock, developed ARDS, had seizures, had acute kidney injury. And really then, again, in hindsight and reviewing all the investigations that we did, this child unfortunately demised, but was actually a PIMS TS. And again, also a complication of these other ways that COVID is now presenting in terms of the DKAs and the new onset DKAs. And then we've recently now hit a 10-year-old patient who fits the classic criteria for PIMS TS. And is that partially because we're now in that phase where we're 3 to 6 weeks later from our search? However, this child, I think, is PCR positive because we're not doing serology testing. So that, again, is not really fitting into the sort of classic case progression that the Canadians were describing. So if we go back, what was that initial UK experience? They had these 38 cases, and you can see it was localized to a specific area predominantly. And they had predominantly shock as their presenting sign. If we look at the patients and those couple that are presented to you, that wasn't our presenting symptom in most of our patients, of which 51% had myocardial involvement. My cardiology colleagues have looked at all of our patients, and we actually found that they didn't have myocardial involvement, particularly those 3 patients that I presented earlier. Many of them had a rash, they had the conjunctivitis and mucomembrane, so again, supporting the Kawasaki's disease, very important. 57% of those 38 children had abdominal involvement. So for me, the important part there is that it's priming us. It's making us think about the abdominal involvement. We're not just writing that off as acute gastroenteritis. If there's SARS-CoV-2 plus abdominal involvement, it needs to be priming us towards, is this possible? Is this PIMS TS possible? A fair amount of them had acute kidney injury. However, not many required renal replacement therapy. And unlike the adults, 32% only had respiratory symptoms. So again, stating that this is not a disease similar to adults. The lab features are very similar to what we've described. The echocardiographic features, 19 out of 25 of them had echoes, 8 of which had some significantly impaired ventricular function. So therefore, mandating that these children do get cardiology services, or at least echocardiographic services, and then consultation thereafter. And you can see that a whole bunch of them, 5 of those children, had dilated coronary arteries. The important thing here, and I just want to highlight on this slide, was that the majority responded to treatment. So again, if we treat these patients, they do well. If we go back to the American study, you can see here that there's a significant proportion of these patients that 80% of them had cardiovascular involvement. There were some biomarkers, of which at least 50% of them had elevated troponins, which means that there was an enzyme leak, and many of them had these increased pro-BNP, this study did BNP levels, not pro-BNP levels. 91% of them had echoes, and they found that there were quite a significant number of cardiac abnormalities, of which there were even 12 arrhythmias, and half of those patients, half of the 186 patients required vasopressor or vasoactive support, of which very few of them were then on ECMO. What's interesting in this study is just to show you, again, how respiratory is very low. The gastrointestinal, cardiac, hematology, mucocutaneous, these were the most common organ systems involved, not respiratory, again, making us think differently than the adult presentation of this disease. And again, here you can see between 50 and 75% of all their patients had all of these biomarkers that suggested, putting all of those together, suggested that they fit that PIMS TS case definition. So if we have a look at, and we just have gone through what Kawasaki's disease classically is, and this is a great table from the Canadian Paediatric Society, where here's the common, they're less than 5, so the pre-COVID pandemic, less than 5 years old, they were majority East Asian children, and that certainly was the way I've been primed in our cardiology clinic, that if those kids flag, those are the ones we're looking for Kawasaki's disease. And you can see that there was very mild, maybe a marked elevation in CRP, but all the other symptoms, very, very mild, of which thrombocytopenia was very rare. And you can see how here, older age group, much broader ethnicity distribution, and loads of other, significantly raised other areas looking at sorry, here we go, at all these criteria of much. So you can see a very different presentation to the classic Kawasaki's disease. Now, coming back to that American study, and as I said to you, what treatment implications do we have? Well, and sorry, this was for my cardiology colleagues, that we did they did a hell of a lot of echoes, and actually not that many flagged with these significant, what you would do for Kawasaki's disease, significant coronary artery aneurysms, where obviously then your follow-up and your treatment effect with regards to high-dose aspirin, etc., becomes important. But for me, for this particular talk, the intravenous immunoglobulin, so polygam, you can see that 77% of the patients got polygam. Okay. Systemic glucocorticoids, so in the form of either oral prednisone, methylprednisone, or as we know now, dexamethasone, but in this study it was methylpred or oral pred. You can see 50% of the patients received an anticoagulation therapy, which we know we've been primed to from the adults, 47% of the patients. Now those, tocilizumab, anakinra, all these fancy therapies that are very, very expensive that many of us don't have access to readily. Oops, sorry, I apologize. You can see not very many patients receive these therapies. You can see 8% and 13% receive these therapies. So we can treat these patients exceptionally well, get good outcomes with the therapies that we have available to us in the government and private sectors. So if I just look at, and this is a colleague of mine, Barney Schofield at the Birmingham Children's Hospital, they looked specifically, they had 15 children that presented with particularly these cardiac, with cardiac abnormalities. And again, they fitted the PIMS-TS criteria, or not necessarily a criteria, but the epidemiology of the disease. The mean age was 8.8, very similar to what I showed you before. Granted, this is obviously an observational study in a single center. There were 15 patients. They all had the criteria that one would support for PIMS-TS. The important thing here, all patients survived and they were discharged alive. But the important thing here is there was significant cardiac involvement. They had transient valve regurgitation. So in other words, they presented with valve regurgitation, and from moderate to severe mitral valve as well as tricuspid valve and aortic valve regurgitation. Their LV function, so the ejection fraction or the fractional shortening, they both are markers of LV ejection fraction, were decreased. 14 out of the 15 had coronary artery abnormalities, of which by the time discharged, 6 of them were normal. And you can see there were some ECG abnormalities as well. And many of those, 10 out of the 15 patients did require inotropic and vasopressor support. So what treatment did they get? And this is the thread of where we're going with this PIMS-TS story, is that they were immunomodulatory treatment was done on a case-by-case basis, but the majority got, all of them got IVIG 2 grams per kilogram, so polygam 2 grams per kilogram, and then what they call high-dose aspirin therapy, which was 12.5, so 50 milligrams per kilogram per day in divided dosages because of the coronary artery involvement here. If they didn't respond, they may have got a second dose of polygam or IV steroid, of which they used methylprednisone for 20 milligrams per kilogram for 3 days. Those that presented with hypotension, those 10 children, very similar to the management that all of us would do. IV boluses, pressor support. Okay, we don't have ready access to noradrenaline vasopressin, but adrenaline at the pressor dosages would work fine in South Africa. And those that had refractory hypotension, in other words, already on the pressors, you added the hydrocortisone, which we follow from the surviving sepsis guidelines in pediatrics. And they used adrenaline. Perhaps we would use dobutamine for LV dysfunction, and then obviously thromboprophylaxis. An antiplatelet inhibitor, so we would use things like Clexane or enoxaparin. From the cardiac result perspective, as I was just making mention, that 14 out of the 15 had coronary artery abnormalities. There was very specific criteria. This is not all that important in terms of knowing exactly what the problems were, but the important thing there is, again, the other association. So Kawasaki's disease is classically associated with coronary artery disease, coronary artery ectasia / dilation / aneurysm formation, for which obviously later on in life can cause issues, myocardial infarcts, ischemia, etc. Whereas with PIMS-TS, or what these guys were finding, was that you had 13 out of the 15 had AV valve regurgitation, particularly mitral regurgitation, which we know can put a lot of stress on the left heart as well as the lungs, and then obviously back pressure onto the right heart as well. However, when they were treated, 7 out of those 10 improved within 2 days. and 9 had mild to moderate tricuspid regurgitation. So not just the mitral side, the tricuspid side as well. And the important thing is those patients that we said had decreased left ventricular functioning, all of them normalized before discharge, as well as, and these are markers, emapsia and atapsia are markers of diastolic dysfunction. And again, all of that dysfunction normalized shortly before they were discharged and on follow-up. So in other words, in this particular observational study, no one died. They did stay for a fair amount of time, 12 days. All 15 were discharged with improving function, and 12 patients had already been reviewed with no new coronary artery abnormalities. So these patients can do really well if we treat them. I think that's kind of the take-home message I'm trying to get to. So I think we've really gone through an overview of what PIMS-TS is all about. But I think the important thing and what we're finding as our group, looking at these patients on a day-to-day basis, and as things are cropping up, we're finding that these abdominal symptoms mimicking appendicitis is becoming far more common. And the point there is that a child with a fever, a child with abdominal pain, that then is flagging or has this history, because perhaps with us, we don't always get the tests out immediately, but it should be flagging then a possible PIMS-TS spectrum, and we should be investigating for it. We're also finding, and certainly the adults are finding this as well, that new onset DKAs with very complicated presentations, and I mentioned the kid that we had that unfortunately died, should flag us also to think about these, because remember, I mean, DKA therapy hasn't got any crossover to PIMS-TS therapy. So perhaps then, if we recognize it, to investigate for it, we can then get these treatments on fairly soon, and the DKA then becomes a bystander to the primary therapy of PIMS-TS therapy. And then there is this emerging data, particularly in the adults, of primary neurological, particularly encephalitis presentations. And as I said, we even had an index case that presented like that we then luckily treated for PIMS-TS, and the child has subsequently been discharged from the hospital doing incredibly well. So what do you do out there? Well, as I said, as a sort of summary of where I'm going, or what we've spoken about, any child with a fever for greater than 3 days, particularly an unexplained fever, if they've got severe abdominal pain, if they've got hypotension, evidenced by systolic blood pressure less than 70 plus twice the age, or if you're using mean arterial pressure, then obviously the table's according to mean arterial pressure, and any of the clinical presentations of Kawasaki's disease, but not meeting all of them. So like in our one patient, the encephalitis patient, just had conjunctivitis, and then later on we found out had GIT symptoms. So in other words, any of these Kawasaki disease features, that mucositis, the cracked lips, the strawberry tongue, etc., we've got to be thinking about PIMS-TS. And so doing the screening investigations, and what would those be? Well, these would be the classic start, where the neutrophilia, the lymphopenia, low platelets, high ferritin, and I see here it isn't D-dimers. We would classically add on the D-dimers, but your big trigger would be a CRP. And in fact, in our patients, the CRPs, in fact, the one patient I think went from a CRP of 1 to 290, if I remember correctly. So significant jumps in CRP that yes, you can see from streptococcal infections would be a classic one, but you've ruled that out. And especially with these other associated biochem abnormalities, then think of PIMS-TS. So my second last slide is really now saying, what about cardiac arrest? And sorry, I know this is an entire other topic, but I think it does warrant a mention to say that we know in our guidelines that PPE is critical for healthcare worker protection. And so many of our CPR guidelines say you need to, well, in fact, our CPR guideline does say, and anywhere around the world says you must don with PPE, particularly because, and I think Netcare has done 2 or 3 sessions on CPR, because of the aerosol generating procedures that CPR, as well as the airway management, creates. And that's offset also by a COVID adult who is at that point of deterioration where if SARS-CoV-2 is the result of that arrest, are you going to be able to reverse that arrest? So we're not talking about obviously a dislodged endotracheal tube or a disconnected ventilator that now is an acute hypoxic event where if you reverse the hypoxia, the patient survives. We're talking about obviously a disease progression. And the question then is, we extrapolated that to children as well. And with a little bit more variation, I guess. But the point is that if we now look at SARS-CoV-2, and if we look at PIMS TS patients particularly, these patients aren't, and many of them, by case definition, have serology exposure. So do they even need to be looked after in a COVID ward is another question. In fact, with us at Barra, if the PCRs are negative, we are looking after them in our main ICU, which has shown a little bit of controversy. But the point is that then they're not infective. So then should we not be using standard CPR protocols for these types of patients? In other words, saying that even though they're being labeled under the COVID banner, they're not COVID infective. And therefore, do we delay that 10 minutes or potentially up to 10 minutes of donning before perhaps only hands-only CPR is started with the sort of lower grade PPE that most of us are wearing anyway in the hospitals? So it does warrant a discussion, and certainly perhaps a review of pediatric resuscitation guidelines within your various institutions. Again, I say that very tongue-in-cheek, and that's why this is a tug of war, because we also know that there are other presentations of COVID, or COVID is riding along as a bystander in many other pediatric diseases, of which many of them are respiratory, and in which case then these children may be infective. And if that is an end of a disease process, should you then be going back to the COVID-19 CPR guidelines? And so it does make it fairly challenging and difficult. But I think the point has to be made that this doesn't go back to our very controversial CPR guideline that we first wrote when we thought that whatever happens in adults is what's happening in children. And so with that, I thank you very much. And I think this is the best quote from Nelson Mandela, that history will judge us by the difference we make in everyday lives in children. And I think what we've now shown is that from all this data, PIMS TS is 100% treatable condition. Catch it early, go down your IVIG therapy, plus minus your steroids, especially if they're not responding with your steroid therapy. And within 7 days, these kids should be going home. So thank you for your time and attention. And I hope this was valuable to all those that were on this webinar. Thanks, Chris.
Dave, thanks so much. That was absolutely brilliant, and a lot to digest there. There are a few questions on the sidebar, and I'll just remind everybody, you can either raise your hand, you can type your questions on the sidebar. Dave, I'm not sure if you can see it on your side. I will verbalize the first question. Is the DKA due to a direct effect on the pancreas? And did the DKA persist after recovery?
Chris, I know that there are a whole bunch of my intensivists that are on this webinar, and I would challenge all my colleagues who are probably better experts than I that can possibly answer this. And for me to answer that question, I actually don't know. But the point, I think, being that this is a dysregulated hyperinflammatory / immune problem that is happening 3 to 6 weeks later by classic definition, which means that there most likely are, and why does polygam work? Because there are most likely these autoantibodies that are being created. Now, does that mean that they've attacked the pancreas? Well, common sense and sort of if you just follow sort of a standard pathophysiological way of thinking about things is, yes, that would make sense. Typical of many of the other viruses that we know do affect children. I mean, when we've looked at our DKAs that we've managed, particularly in our private ICU, we've gone back, and in certain cases, we've actually proven some of the viruses that could have been the causative agents to the B cell destruction. So, and many of them have been respiratory viruses, actually. So that association definitely is definitely plausible. Whether it is or not, I'm not 100% sure. And again, the reason why the question marks in my head around this is, why didn't we see this in China? Why hasn't all of this come out of there? Why are all of these presentations happening much later? Were they not reported? Maybe. Or has the virus changed in its strain, and obviously has it mutated? Well, that's also plausible. So I think there are a couple of unanswered areas there, but very interesting to then hopefully get the answer in the future. I don't know if we just are too new in the disease process to know if that is a actual fact or not.
Thanks, Xavier. So it's definitely some food for thought there. The next one is also from Dr. Aspat. Are the abdominal symptoms, i.e. the mimic appendicitis, due to mesenteric lymph node involvement? And then there's quite a few GIT questions, so I'll just line them up. How is the diarrhea treated? And is there a reason for the predominant GIT involvement in children?
These are great questions, really great questions that I must be honest, I don't have perfect answers for. So mesenteric lymph node involvement makes a lot of sense. Remember that if we take non-COVID era patients, and we know that to potentially new or surgeons that operate on children that don't look after children very often, there have been many appendicitis type exploratory laparotomies that then yielded mesenteric adenitis as their diagnoses. So it's again absolutely plausible that could be what the cause is, particularly because we know that part of the Kawasaki's disease presentation is the cervical lymphadenopathy presentation, and then also the arthritis, the arthralgias. So all of that does go with this generalized inflammation, which we know is then housed in the lymph node areas. So I would agree. I mean, as I say, I certainly don't have a definitive answer on that, but I would agree that does make sense. That generalized abdominal pain most likely is mesenteric adenitis. And so I think we've had now three cases that had exploratory laparotomies that were negative laparotomies, and obviously blamed on the appendix. However, the reports that came back didn't say that there were specific large mesenteric nodes, but we know that mesenteric lymphadenitis doesn't have to necessarily have very big nodes. How is the diarrhea treated? That's still standard supportive care. And the reason for predominant GIT involvement, I'm not sure. I'll definitely phone a friend on that one if there is one that can help. I'm not sure why it's predominant GIT. Again, my guess would be that it's that systemic inflammatory, but that would mean that the lungs should often be involved because they house a lot of the cytokine. You know, if this was a cytokine storm type presentation, which we know it's not, because obviously that's how the adults present. But if there was a cytokine storm type presentation, we know the lungs get affected quite severely on that, which then wouldn't explain why the abdomen's the predominant involvement. So I'm sorry, I don't actually know exactly what the answer there is.
Thank you. I think that's a fair response. I see, William, you've raised your hand. I'm just going to unmute you quickly. You can unmute on your side if you want to verbalize your question.
Hi, yeah, sorry. Thanks for taking my call. How's it, Dave? It's Will here.
Hey, Will.
I just wanted to ask, so you're talking about this PIMS TS coming through sort of 3 to 6 weeks after a COVID infection, and where there is, may or may not have been a positive COVID swab. But you also know that patients, the COVID swab, even the PCR, stays positive for 3 up to 4 weeks after they've been infected, and are presumably asymptomatic, non-infectious, but are still showing, presumably from viral particles, whatever. So now if you've got a patient who's got this PIMS TS and they swab positive on the PCR for COVID, do you still put them in a normal ward? Would you put them into a COVID ward? And are they still infectious? What's the thinking around that?
Well, that's a great question. Thanks, Will. And that's exactly the sort of controversy that we've been sitting with. And in fact, that Paediatric Intensive Care Interest Group had this discussion as well, or had this debate, because, as you say, you can virally shed for a while. And if you look at many of the guidelines for the latest guidelines in terms of the self-isolation for 10 days post-exposure, or even returning back to work between 10 and 14 days post-infection, not needing to have a repeat COVID swab before you return to work, knowing that there is a potential for viral shedding, makes that quite a difficult decision. But I think the point with us at this stage of the disease process is that if the PCR is positive, you don't know where you are in that process, and so we would then still treat them as infective patients, and then that would be under the COVID ward. And in fact, that's, I think, exactly how we're managing the patients at the moment. In fact, I think the kid that we had is now sitting in the COVID ward, is he not? After we thought that he was that classic post-exposure, having a negative COVID swab. I believe there is a positive swab now, and so we have put him into the COVID ward, as far as I understand. I think you'll probably know better than me, Will. But I think the point is at this stage, where this is still very sensitive and we don't exactly know, then you still are going to take those precautions, absolutely, if there is a positive PCR, because you're not quite sure where they are in that process. And I think also that's on the background of those other cases that I presented to you, where we didn't know. We still are trying to get, none of our kids, apart from this particular one, which I don't know, you probably saw today, I guess. But other than that, under this particular one, all the others haven't fitted this classic case definition, which has made it even more challenging. So those kids definitely have all been under the full protection, full PPE banner, and then nursed and obviously looked after in the COVID ward. Chris, I see on our chat line, Professor Peterson, who's our head of our renal unit at Barra, just put a comment, particularly for the mesenteric and certainly the severe abdominal pain, to actually consider mesenteric ischemia due to the thrombotic events that could occur as well. So I think that's an excellent, and that should be looked at, and perhaps again that is a good word to our surgeons that then open these patients up to actually have a really, really thorough look to make sure that there isn't any macrovascular evidence of ischemic thrombosis.
That's a very good point. Thanks, Dave. And thanks, Prof. Peterson, as well. I see we have gone to 7:10, and I don't see any other questions. So I think we'll close it off there for tonight. Dave, thank you so much. And that was a brilliant talk, and definitely an area that we haven't covered or touched at all into the pediatric patients. So some good insights there. Mandy, I'm not sure if you want to close off as well.
No, I just want to thank Dave. I always spring these things on my friends and ask them if they're prepared to do talks, and there's not one of them that said no. So I really appreciate it. It's been a wonderful session and really good to have you on, Dave, and I really appreciate it.
Thank you so much, man.
Perfect. Okay, thank you, everybody. As a reminder, our next session will be on Wednesday night, so there won't be a session tomorrow night. The next one will be on Wednesday, 5th of August at 6 o'clock again. We're fortunate enough to have a session on the positive maternity patient and her baby, being done by Dr. Bronwyn Moore, one of our specialist gynaes from Park Lane, the lead obstetrician there as well, and with a lot of experience and knowledge to share. So thank you all again for joining us tonight, and we'll see you again on Wednesday evening. Thanks again, Dave, and have a good evening, everybody.
Good night, everybody, and thanks again to you guys.